Thank you, Fee. I'd like to just start with a disclosure. So I'm struck, in the United States, you'd always see financial disclosures at the beginning of each talk. I have no financial disclosures, but I probably have what Fee has traditionally called an intellectual conflict of interest. So I am on statins, and I just want to make that clear. So when I left Chicago, I did take the statins on Thursday and Friday, but I know the evidence changed when I got in the airplane and landed in England, so I stopped taking them this morning. Because I do know there's shifting evidence, but I do follow the controversies at the different journals. Many of us are friends, and so I really want to acknowledge that. I appreciate the statin controversy that erupted in the pages of the BMJ, and I thought Fee, as traditionally she has done, has handled it with great intellectual effort and appropriately. I was accused of journalism malfeasance early in the year by the Androgen Study Group, and I report to the Journal Oversight Committee. So there's a system in place at JAMA when there's accusations of editorial misconduct, and I think like Fee, these create an enormous opportunity for us to understand what we do and how well we do it. I think, interestingly enough, this is in part in contrast to what happened at The Lancet when there were concerns about anti-Semitism in their pages, because I don't think there was a system in place to understand whether or not the editor-in-chief had handled it appropriately. And Richard and I have talked about that at length, but I really want to acknowledge that I thought the way that Fee handled the statin controversies really have held journals and journalism in good stead. I'm going to talk briefly about clinical decision-making. I'm aware that I stand between you and a coffee break. Remind people of the IOM checklist for guidelines, which was violated by the AHA-ACC statin guidelines. And then, interestingly, there's been two very interesting guidelines last year, obviously lipids and statins, and then JNC8. Now, interestingly enough, JNC8 is a more restrained guideline around the treatment of hypertension. Generally was criticized by the hypertension community about being too restrained. It actually suggested less treatment than in the past, whereas I think many people know that the statin or lipid guideline clearly had expanded treatment. So you have two guidelines released within 3 months of one another, one more restrained, one far more expansive. And then we've had numerous opinion pieces, we call them viewpoints, about the issues both related to JNC8 when we published the guideline and had a number of editorials and viewpoints, and then viewpoints on the statin guidelines, which were published in Circulation and JACC. And then just some concluding remarks. For me, this is really the characteristics of how decisions are made. Patient's preference, physician experience, and evidence. But these are not created equal. And I think that's an error that constantly confronts us in clinical decision making. So for chronic disease, end-of-life care, cancer care, I think it's incumbent upon us to ensure that patient preference drives clinical decision-making. On occasion, there'll be evidence, but often there will not be evidence. I think Richard spoke about the randomized clinical trials not being representative. We know that oftentimes comorbid conditions are not part of randomized clinical trials. Most adults develop comorbid conditions, so the inability to inform decision-making based on RCTs only increases. And then obviously we hope that patient experience or patient biases begin to influence decision-making. But that's really in contrast to acute disease. I've rarely had in my time as a practicing pediatrician ever have a parent really say to me they'd like this test or that test when their child was at risk for an acute infection or was suffering from an acute infection. So I think there's very good data that most patients are much more comfortable turning over care to physicians when there's an acute illness. It's when it becomes chronic disease or the decisions are more around preventive care, like screening for mammography or prostate cancer, when patient-centeredness becomes more important. Now, I do think in the years to come we're going to struggle with when patient-centeredness drives us to decisions that we think are wrong. and how do physicians deal with that? Patient-centeredness may not always drive us to the best decisions. And in some regards, you've seen that in the UK over the debate over cancer care and NICE. So when I used to come to the UK regularly when I was within the BMJ system at ADC, I would have said that NICE really focused on very clear evidence-based decisions. But I think over the last couple years, it's been far more influenced by patient-centeredness. And I'm not sure that's always driven the decisions based upon evidence. But these decisions are really influenced by societal norms. And I think they have fundamentally changed over the last 10 years. So 10 years ago, we were interested in doing more to patients. And I think now has emerged concerns that we're want to do less or do more appropriate care. And in the United States, that's really been characterized by the Less is More campaign that Rita Redberg has championed in JAMA Internal Medicine, or the Choosing Wisely campaign, the Choosing Wisely campaign Canada. I know there's the equivalents in the United Kingdom. But there really have been changes in the trends in the way we think we should act within medicine. And I think that's really become a huge issue as we develop more and more guidelines. In some regards, the goal for guidelines have become more restrained. They've asked less questions because they've really tried to focus on randomized clinical trials. But since there's only evidence for 25% of the decisions we make, if we only rely on randomized clinical trials, then you're going to be offering less and less guidance to clinicians. And so I think we really need to understand that clinical decision-making is influenced by the norms of a society and the healthcare system itself. And these are constantly changing and evolving. I'm sure you've been engaged in the same debate about treatment for hepatitis C that we've had in the United States. So treatment for hepatitis C in the United States, about 3.5 million people, average cost is about $75,000. It would bankrupt many healthcare systems, but the new treatments are highly effective with sustained viral rates approaching 90 or 95%. So societal norms are going to dominate how we make decisions about this drug and this treatment. And I think this is going to be an evolving issue over the coming years. And you need to understand that your own opinions, your own feelings, your own biases may change as you get older or you gain more experience in healthcare. These are the IOM recommendations. Now, interestingly, these are the IOM recommendations for developing guidelines, and they're entirely based upon consensus. So I'm always bemused when guidelines on guidelines are actually based on consensus and no evidence. But there are 6 or 7 major standards. The first is transparency. The process and funding of the guideline development should be completely specified. Second, conflicts of interest. Conflict of interest include commercial, institutional, professional, and intellectual conflicts of interest. Now, the IOM is very, very careful, for example, when they're putting together a committee to offer a report, that they don't look just at financial conflict of interest, but they examine the legacy of an individual's publications. Because you know, for example, if you ask Rita Redberg to be on a committee, she's going to have a very different opinion about certain types of cardiologic procedures than Roger Bloom would at Johns Hopkins. They just have very different opinions. And so the IOM is very careful not to balance financial conflicts of interest, which are easy to find and to detect, but intellectual conflicts of interest. Group composition. The guideline group should include multidisciplinary methodologic experts, clinicians, and patient advocates. Systematic review of evidence, grading strength of recommendations, articulation of recommendations. Recommendations should be clearly stated and actionable. External review. The draft guidelines should be posted for public comment, and the final guideline should be revised as appropriate before peer review. This has raised a huge issue. In fact, the JNC8 hypertension guidelines were open for public discourse, and because of the comments offered through the JNC8 review external process, modifications were made in the final recommendations. The AHA-ACC guideline was not open for public comment. In fact, it moved from an independent body into AHA and ACC, and was moved quickly through their guideline committees in a few months so that it could be published in in conjunction with their national meeting 2 years ago in November. And it's probably this lack of external review that only has made the guideline more controversial. And then updating guidelines should be updated when new evidence could result in modifying the recommendations. Now, the American Cancer Society will be releasing a number of guidelines this year that I'm quite certain will be controversial, but the American Cancer Society has gone one step forward. So in general, the writing committees for the American Cancer Society are methodologists rather than content experts. So the content experts advise the committee, but the writing of the guidelines are done by methodologists. Another very substantial change from the way guidelines have been written before, particularly by specialty societies. So what of the cholesterol and blood pressure guidelines? There was a very limited number of questions, actually only 3. They conducted systematic reviews. They assessed the evidence. They focused on randomized controlled trials, and they acknowledged that only 25% of the decisions around hypertension could possibly be evidence-based. Now, turning to the ACC-AHA guidelines released in 2013, they were released by a specialty society. I think specialty societies will continue to release guidelines, but I don't think they followed many of the recommendations of the Institute of Medicine, which was interesting because at the time of release, I would have expected that there would have been more criticism about their lack of following the recommendations of the Institute of Medicine. These are the guidelines that we published on the JNC8 report on hypertension. And we did a few things, so it's almost impossible for journals to review guidelines. I'll be perfectly honest, we publish a few a year. We published 3 last year, 2 on HIV disease, prevention and treatment, and 1 on the JNC8 panel. But these documents go to hundreds of pages with the systematic data available in supplements. It's impossible for any single peer reviewer to repeat that process. So how does a journal, or how did we at least JAMA review the guideline? We really review the 20-page summary statement for clarity more than anything else. And what we mean by clarity is so that if there's uncertainty, we ask the authors of the guideline to offer additional language so it's very, very clear. We also ask them to acknowledge uncertainty or when the evidence is weaker. So for example, we published the sickle cell guidelines, and based upon the grade recommendations, they had a number of recommendations that were based on poor data or inadequate or insufficient data, but they gave it a very strong recommendation. So we insisted that they explain each time that they had done that, where there was a strong recommendation but moderate evidence, why they made such a recommendation. Why is that important? Because in the United States and around the world, strong recommendations often become quality indicators. And quality indicators can drive reimbursement in the United States, and it can also drive assessment of how well individual physicians or healthcare systems are performing. And so when there's a disconnect between the evidence and the recommendation, we feel it's very, very important to explain that. In addition, unlike when the AHA and ACC guidelines were released, Eric Peterson, Mike Gaziano, and Phil Greenland, our associate editors in cardiology, actually wrote a criticism of the JNC8 guideline and how they disagreed with it and why they disagreed with it. So we tried to offer greater context for the JNC8 guideline than I think was offered for the AHA-ACC guideline. I've already said I think there's changes in society. You have questioning of authority. That starts with patients, but I think all of us grow up and are informed by society. So because there are changes in society about physicians as being authoritarian figures, it's likely that we as individuals and then organized medicine are going to question authority. And in some regards, that's what guidelines represent. I've already mentioned the less is more and the Choosing Wisely campaign. And then the general global concern that in resource-rich countries, it's time to think about whether or not we're practicing too much medicine. And these are just a few of the opinion pieces that we've had that accompanied the guidelines, the Stanton guidelines after they were published. This is by John Ioannidis. I think many of you know him. He's currently at Stanford. one of the great modern thinkers of methodology. My training was in New Haven. I had the fortune to be trained by Alvin Feinstein and Ralph Horowitz when I was in New Haven. And Alvin is often considered, with a number of other people, one of the fathers of modern epidemiology. And I would say John now, I think, holds that mantle. And I would also say John is a far kindlier version of Dr. Feinstein. More than 1 billion people taking statins, potential implications of the new cardiovascular guidelines. So again, I think if the AHA, ACC, when they published their guidelines, had some opinion pieces that had talked about what the potential implications were, the seeing rebuke of those guidelines would not have been as substantial. Victor Montori, who I think more than virtually any other individual has worked hard to understand how you incorporate guidelines into practice, the optimal practice of evidence-based medicine, incorporating patient preferences into practice guidelines. I think Dr. Pito said it much. It's important for us to get the data correct, the evidence correct, but the ultimate decision isn't ours. The ultimate decision is the patient's. Getting the evidence right, the right option, outcomes, and outcome data is an obligatory prerequisite for considering informed patient preferences. And something that was unusual for us, but we presented patient vignettes in our opinion pieces. And I'll just read this one quickly. This is part of the Montori viewpoint. 65-year-old woman with no cardiovascular disease, average blood pressure 135/80, LDL 200 milligrams per deciliter, HDL 30 milligrams, total cholesterol 300 milligrams. She didn't change with diet, rarely ever changes with diet. She has been unable to tolerate the statin because of GI disease and muscle discomfort. She returns to discuss follow-up. Following ATP3 guidelines, a physician would prescribe another statin to reduce her LDL to cholesterol. The new ACC AHA guidelines give a class 1 recommendation to use moderate to high intensity statin. Rather than merely prescribing statins for this patient, the physician used a decision aid to discuss the value of reducing the 10-year risk from 10% to 6%. There's an accompanying video. This patient considered her options and chose not to use statin therapy. So the reason why this is an important case is if this physician's quality measurement was being assessed, this patient in the American healthcare system may have ended up being measured or being as assessed as being practicing inconsistent with the guidelines. And that's why when evidence is weaker, we need to be very clear about what the final recommendations are. But I think Dr. Montori would say this was a perfectly reasonable outcome for this patient, presenting the evidence and letting them together make the decision. And this goes back to my model that around chronic disease or preventive medicine, the patient circle, the patient domain should be much stronger in the way that we make decisions. And this is the second case, and then I'll move on. Second patient, 45-year-old woman who's moderately obese, type 2 diabetes. Hemoglobin A1C is in relatively good control. ATP3 guidelines, the patient's diabetes should be considered coronary artery disease equivalent. She should use statins to reduce her LDL. Second paragraph, under the new ACC-AHA guidelines, moderate to high intensity statin therapy for primary prevention is recommended, class 1 recommendation for persons age 40 to 75. Further, this patient has a 10-year cardiovascular disease event risk, blood pressure 135, total cholesterol 200 of 3%. That's her 10-year CVD risk. By using a decision aid, the patient learns that statins can reduce this risk to 2%. So you could either say it's a 50% reduction or an absolute risk reduction of 1%. From her perspective, she believes that her CVD risk event is low and that the benefit also seems insufficient to justify taking statins for the next 10 years. Again, from my standpoint, this patient reached the right decision for herself. The data were presented to her, the decision aid was used, and she decided in both cases not to take statins. In both cases, both decisions would have been inconsistent with the AHA-ACC guidelines, but they were the right decisions because the patients made it for themselves. This is patient 3. This patient ends up taking statins, so Victor tried to be fair in presenting the case vignettes. The new cholesterol guidelines and blood pressure guidelines, I think people in this room are probably familiar with Harlan Krumholtz, because I think he was on the committee that evaluated the publication in the BMJ. Emerging from these documents, these are the AHA guidelines and all of the controversy, the various opinion pieces in BMJ, Lancet, New England Journal, JAMA, Annals of Internal Medicine. Emerging from these documents and others is a sense that guidelines should inform but not dictate, guide but not enforce, and support but not restrict. And then one of my favorite pieces, in some regards it was interesting to hear Dr. Pito talk about magnesium sulfate and aspirin, reversals of established medical practices, evidence to abandon ship. And Dr. Ioannidis talks about how most captains want to go down with their ship, and that's often true of many of us who hold on to our old biases or the evidence that we understand or remember. We really want to go down with our ship, and he would argue in medicine that's probably not the best approach. I'm always struck by how people read the literature. In general, most people read the literature that agrees with what they think and tend to avoid reading the literature that usually challenges what they think. But I don't think anyone can articulate kind of modern epidemiology and its interaction with decision-making in medical journalism quite like John can. And so just a few conclusions. I think it's clear clinical decision-making is more complicated now than in the past. Patrick touched on whole exome sequencing, clinical exome sequencing. We've had a few papers in that area. The notion of personalized care, particularly in cancer and oncology, and whether or not genes will drive us to successful patient differences in outcomes, I think is unclear. I must say I am quite concerned, though, that in this case we may adopt certain types of personalized medicine based upon genes in cancer before there's substantial evidence to suggest it will truly change outcomes. More evidence now exists with increasing reliance on randomized clinical trials. However, we've now heard for almost a decade that many of the people enrolled in randomized clinical trials don't represent the greater population. And we've also heard that very few randomized clinical trials don't do very well with comorbid conditions. So I think we are going to continue to have to use much of the art of medicine to understand how to incorporate data from randomized clinical trials into decision making. Medicine is more focused on restraint, particularly in resource-rich countries. Now that's in contrast to personalized medicine and genetics, where there appears to me to be no restraint. So you have contrasting trends that I think are going to evolve over the next couple of years, and I'm not quite sure how they will tilt in particular areas. Creating trustworthy guidelines may not be possible. Regardless, less evidence should mean recommendations are less robust. I will give one example of a terrible recommendation in the United States that led to a great deal of disease. So I think for many years we've struggled with any good evidence about nutrition. I think we already heard a discussion as to why nutritional evidence is so difficult to mount. But about 10 years ago in the United States, the American Academy of Pediatrics suggested, based upon limited evidence, that pregnant women should avoid all allergenic foods, particularly peanuts, both during pregnancy and then the first 6 to 12 months after an infant was born. That included peanuts, eggs, and other highly allergenic food. There was a single observational study published in the British literature that compared Jewish children in England to Jewish children in Israel. Jewish children in Israel actually see a paste that contains peanuts early in their life. In that observational comparison study, at 3 years of age, the risk of peanut allergy in the Israeli population was 10-fold lower than it was in the population in England, where there was very clear data that the population had avoided peanuts. So based upon observational data, we had said avoid peanuts. Then one study suggests we shouldn't. About 3 months ago, there was an RCT published in New England Journal of Medicine that exposed infants early in their life to forms of peanuts, and the risk of allergy at age 5 was about 10-fold smaller. And so I think we need to be very careful when evidence is based upon observational data to be very clear about the types of recommendations that we make. Guidelines must inform but should not dictate practice. And finally, practice is science touched with emotion. Thank you very, very much.